Azora, we can now start. Sorry, you have to unmute yourself, I think.
Hello and welcome to the WHO media briefing, which is taking place in collaboration with the APO group. I'm Zora Machekanyanga. First, some housekeeping. You can choose to listen to the press conference in French or English by turning to the globe on the bottom right of the screen and selecting your language. Khadija, please explain in French.
Donc, vous pouvez choisir d'écouter la conférence de presse en français ou en anglais en cliquant sur le globe en bas à droite de l'écran et en sélectionnant votre langue.
Thank you very much. Merci, Khadija. Joining us from Brazzaville, Congo, is Dr. Benito Impuma, who is the Director for Communicable and Non-Communicable Diseases at the WHO Regional Office for Africa. I will now let Dr. Impuma introduce other panelists.
Well, thank you very much, Zora. Good morning and good afternoon. Bonjour or bon après-midi to all the journalists joining this press briefing on the COVID-19 pandemic in Africa. We'll also discuss the latest trends in routine immunization in the region, as well as the ongoing response to Ebola outbreak in the Democratic Republic of the Congo. A brief update on the ongoing Ebola outbreak in the Democratic Republic of Congo will be given by one of our colleagues. I'm very pleased to be joined for this conversation by the Honorable Dr. Kailash, Minister of Health and Wellness in Mauritius. I'm also delighted to be in this discussion with Professor Helen Royce, the Executive Director of the Vet School of Vets Reproductive Health and HIV Research Institute based in Johannesburg, South Africa. Welcome, dear colleagues. Let me start by first commending Dr. Kailash on the exceptionally high rate of COVID-19 vaccination in this country. And of course, Professor Helen Royce, in our role as Regional Immunization Technical Advisory Group Chair, has been very pivotal in guiding the immunization activities across the WHO African region. Once again, many thanks for the support you've been giving to this region. This week, new COVID-19 cases and deaths on the continent increased for the first time after a decline of more than 2 months for cases and 1 month for deaths. To date, Africa has recorded more than 11 million cases and almost close to 250,000 deaths. This uptick is largely associated with the increase in the number of cases reported from South Africa as the country enters its winter season when respiratory illnesses become more prevalent. Just in the last week, the country's cases have doubled and there's a small increase in hospitalizations. Although the Omicron variant continues to mutate, there is no current evidence to suggest that this new upsurge is linked to any new sublineages or a new variant. But this shows that people must remain vigilant and continue to adhere to public health and safety measures such as wearing a mask, washing hands, and social distancing. And of course, getting vaccinated. Turning to vaccines, this week we are marking African Vaccination Week in conjunction with World Immunization Week. This is an opportunity to underscore the importance of vaccines in our lives. We are marking this week in the context of 2 years of disruption by the COVID-19 pandemic, which has had, as you all know, major effects on the provision of routine health services, with immunization being seriously affected. Inequalities in accessing vaccines and disruption by the COVID-19 pandemic, including its huge strain on health systems, have impaired routine immunization services in many African countries and forced the suspension of vaccination drive. Across the region, tens of millions of people are still missing out on the scheduled immunization against vaccine-preventable diseases. Over the past year, for instance, outbreaks of vaccine-preventable diseases have increased in our region. I'll just give you some statistics to illustrate this. For instance, between January and March of this year, around 70,000 cases of measles were recorded. This is a 400% increase compared with the same period last year. Outbreaks of other vaccine-preventable diseases have also become more common. For instance, 24 countries in our region confirmed outbreaks of variant of polio last year, which is 4 times more than in 2020. Last year also, 13 countries reported new yellow fever outbreaks in the African region, compared to 9 in 2020 and 3 in 2019. But in spite of the disruptions of the past 2 years, we can say there are positive messages coming out of the lessons learned from our collective response to COVID-19 response. I'll just highlight some of the few lessons. WHO and partners are supporting African countries to carry out catch-up routine vaccination campaigns. More than 30 African countries implemented at least one routine catch-up immunization campaigns in the second half of last year. And this year, countries are showing progress with measles and yellow fever campaigns starting again. Central African Republic, Chad, Equatorial Guinea, Ethiopia, Nigeria, Somalia, and South Sudan have reinstated measles campaigns, which is a good news. Additionally, some countries have successfully integrated other critical immunization campaigns with COVID-19 vaccination. For example, Ghana integrated COVID-19 vaccination with yellow fever campaigns in December last year to curb an outbreak. Nigeria recently launched a vaccine scale-up strategy, which guides the integration of routine immunization with COVID-19 vaccination for mothers and their babies. And the spin-off is that these mass vaccination campaigns are also boosting COVID-19 vaccine uptake. This year alone, for instance, coverage has increased by 6%, from 11% in January to 70% in April. But this is not all about mass vaccination campaigns. WHO is committed to supporting countries to strengthen essential public healthcare services to deliver COVID-19 and other vaccines. And in doing so, further the aim of universal health coverage. These long-term solutions, we believe, will bring benefits to communities in our region beyond COVID-19. I look forward to our discussion today, and once again, thank you for joining us. Back to you, Zora.
Thank you very much, Dr. Impuma, for that update. Let me turn to Professor Rees. Could you please tell us what is the importance of scaling up routine immunizations?
Well, I think we've just heard very clearly stated by Benito that it's absolutely critical. And when you see routine immunization coverage drop, this is when we see outbreaks. And if you think about things like measles, like yellow fever, like polio, we know repeatedly that if we got routine immunization coverage up, we would be able to prevent the outbreaks that we're seeing. So that's the first thing. The second thing is that we've got to be consistent in what we're thinking about the importance of good health in terms of core development issues. So we recognized with COVID that if we allowed a pandemic to go rampant, as it managed to do, but we're trying to now contain it, that this is not only a health issue and it's not only a burden on our hospitals and so on and mortality rates, but it's a huge impact on human development, on economies, on job creation, and on poverty. Now, we've also known that for routine immunization, the same is true. It's not only extremely important, we tend to think about it as childhood immunization, small children. It's not only saving the lives of the under fives. Routine immunization has now extended into things like human papillomavirus. We're going to see extension of routine immunization in the future in our region to the new malaria vaccine, for example. So we know that routine immunization saves lives. But we also must remind ourselves that the same thing is true. If children get sick, caregivers have to stay at home. If children become disabled, caregivers have to stay at home. If children need hospitalization, the out-of-pocket expenses for health, that's significant. So the same is true for routine immunization as for COVID. There's the direct health, morbidity, mortality problem, but there is this spin-off in terms of adversely affecting core development and contributing to poverty, which is absolutely critical for our region. So routine immunization, we shouldn't use that word routine because then it sounds boring. It's actually a core component to uplift communities and particularly the poorest communities and the most vulnerable communities. Thank you.
Thank you very much, Professor Rees. Right now, we would like to go to the Honorable Dr. Kailash Jagutpal, and would like to know from you, could we know more about how Mauritius scaled up routine immunization and COVID-19 vaccination?
Yeah, thank you. Now, Excellencies, members of the press, of the media, it's an honor to me to be among the panelists for this media brief. It's a fact, it's important to highlight the need for well-elaborated immunization programs so as to protect all. Mauritius is an island state with its own specificities. The population being some 101.2 million and with a life expectancy of stood up to 75 years in 2021. Now, our country has a universal free vaccination program starting from birth, and currently we operate in the island throughout some 158 public vaccination points over the island for all the vaccinations. And out of them, we have some 13 vaccines offered, including the vaccination against COVID-19, including the Hpv vaccine, and even the all age vaccines, that is the vaccines for the flu vaccines that we do give for the population. Now, these 2 years have been very challenging with the ongoing pandemic, with the confinement. And as is the case for various countries, we have had to quickly adapt and roll out the vaccination for COVID-19 in such circumstances. Now, we have to ensure that the exercise that we are doing for our routine vaccination, that exercise doesn't compromise with the other vaccines program. So how Mauritius did that? So we devised specific strategies to carry out both these vaccinations and having specific teams employed, dedicated for the COVID vaccination. Now, before all, we had the high-level committee chaired by the Prime Minister, where all the stakeholders are participating, be it concerning quarantine measures, sanitary measures, as well as for the vaccination and the procurement of vaccination. So we had to ensure to get on time the vaccinations and the rollout program so that it can be easily given to the population with target groups. So since the time we started the vaccination, so we have the targeted groups, you know, the frontliners, the above 60s, those with comorbidities, having those target groups to be offered the vaccination in the first instance and gradually extending the vaccination to the whole population. So that was done under the Prime Minister chairing a high-level committee. And since the beginning of the of COVID-19, so we have been having committees daily, on a daily basis. If I remember today, we stood up to more than 375 high-level committees meeting all the stakeholders, the doctors, the administrators, as well as the WHO representative participating actively into the whole COVID-19 issues. Now, this has helped us a lot because this has been a coordinated approach, and we have also the regulations put in place for specific places where you need to have your vaccination pass to enter these locations. Now, with this, we have been able up to now to vaccinate with the fully vaccinated, a population of more than 90% of adults being fully vaccinated. And now we have already more than 60% having been the fully vaccinated plus a booster dose. Yeah.
Thank you very, very much, Honorable Dr. Jagutpal. And now we turn to Dr. Morikater, the WHO Incident Manager for the ongoing Ebola outbreak, where vaccination began yesterday. Dr. Morikater.
Thank you so much. As you might know, the 14 Hpv outbreak in the DRC was declared on 23rd April 2022 by the Ministry of Health. This is the third Hpv outbreak in Equator province since 2018. To date, only 2 confirmed cases have been reported. All have died. Only 1 health zone is affected, Mbandaka health zone. Response activities are underway and all responses are already operational in the field. Vaccination, as we said, vaccination started yesterday with 3 operational teams that vaccinated 78 contacts. In terms of immediate action from WHO, the event have been graded and the SOPs, the emergency SOPs have been initiated. But also the deployment of surge to support the EVD response in Mbandaka, implication of existing staff in Mbandaka, as we have a sub-office in Mbandaka, deployment of an incident manager, and other additional deployment on the way. We are also supporting the supply of Gen Expert cartridges and the shipment of vaccine from Goma to Mbandaka. And our team on the ground is are supporting the Ministry of Health for developing the strategic response plan. And today I can say that everything is going well on the field. Over to you.
Thank you very much, Dr. Keita. Now that we've heard from all our speakers, it's your turn to ask questions. To do this, please use the question and answer function on the Zoom application. And please remember, you will need to provide a name and the news organization you represent to have your question answered. To answer questions, we also have additional experts on hand, and that's Dr. Zubair Jumaye, who is the senior advisor to the Prime Minister of Mauritius and the chairperson of the National COVID-19 Vaccination Committee. We also have Dr. Tieno Baldi, who's the regional COVID-19 incident manager, Dr. Meseret Shibeshi, who is the immunization Officer at the WHO Regional Office for Africa, and Dr. Richelo Ayangma Muko, who is the Medical Officer for the Polio Eradication Program at the Regional Office for Africa. There are questions that have already come through, and if you would like to ask your questions, please let us know. We have questions from Emery Makumeno, who is with BBC in Kinshasa. I'll read her question. I would like to know more about the Ebola vaccine currently being used. Why don't health officials run a mass vaccination campaign DRC-wide to avoid repetitive outbreaks? What is the cost and lifespan? This goes to Dr. Mori Keita.
Thank you so much for this question. But as you know, the DRC has nearly 19 million as population. So can you imagine if we had to vaccinate the entire populations? Even with COVID-19, the country has not yet reached 10% of the targeted population since they started vaccination. So moreover, vaccination against Ebola has been proven to be a cost-effective strategy using the ring vaccination, the ring strategy of vaccinating contact and contact of contact. So today, we know that the vaccine has been approved by the FDA. The ICG managed the global stockpile. So there is not enough to consider such a campaign. With a very good investigation and listing of contact, I think we can be able to vaccinate, to identify contact and to vaccinate them and vaccinate contact to quickly stop the outbreak. Over to you.
Thank you very much, Dr. Mori Keita. The next question is coming from Sarah Gervin from DEVEX, and her question goes, can you please provide more details on the rise of measles cases? And can you give more specifics why the countries are seeing that rise? Which countries in particular, and what is being done in response? This question goes to Meseret, and then Professor Rees can add on to what Meseret would have said. Dr. Meseret, please go ahead.
Thank you very much for this interesting question. As you remember, the COVID control has also some public health measures that countries had to adhere to, with the confinements, with the limitations, and the fear at the beginning. Really essential services were compromised in majority of our countries, where scheduled vaccinations were not provided as they were supposed to be done. Hence, many of our countries in our region have really lapsed in their performance coverage against measles. Very few of them sustained their expected coverage. So due to this missed vaccinations in our countries, children are now susceptible and they are falling to the outbreaks. With the WHO, what we do is periodically and regularly in our countries and the measures to be done. Here, using this African Vaccination Week, we call on our member states to ensure that those children who have missed their scheduled vaccinations should be given their vaccines. That's the only way to prevent the measles outbreaks. Yes, we know we have the lists of the countries, but it keeps on changing. So we'll not list the countries as per your request, but we have communicated to each and every country who is going to face these huge measles outbreaks for intervention. Thank you.
Thank you very much, Dr. Meseret. Professor Rees, would you like to add on to what Meseret has said?
So I think for measles vaccine, you need very, very high coverage to prevent outbreaks. And if your coverage isn't up at 90%, 95% of the at-risk populations, so what happens is over time, you're going to get cohorts of particularly children being born who are not vaccinated, not protected, and you get to a point where you will inevitably have an outbreak. So actually measles vaccination is critically important, and coverage is really, really important. So the other thing I just want to add to this is one of the other efforts that is now really being highlighted in our region is to try and find what we've called zero-dose children. There's a vision for immunization globally, which is called IA 2030, and the focus is on finding zero-dose children. And these are children who've never had a single vaccine. And why is that important? It's important because those children, as you can imagine, are particularly vulnerable. Measles would be a case in point, one of the most infectious diseases we've had and a big killer amongst children, but for every other vaccine preventable disease. So zero-dose children, however, as you could imagine, are much, much higher risk of mortality, of dying. But if you find those children, they're often a red flag in a community or in a family. And those are families that are likely to be more vulnerable in terms of food security, poverty, in terms of women accessing antenatal care. So the vulnerabilities, if you focus on those zero-dose children, are multifold, and all will need to be addressed. So in terms of measles, it's a flag for low immunization. Within that, you'll find some of these zero-dose children who are at even higher risk of many, many things. And so we need to not only address that measles outbreak, but then go back to saying, why is our coverage low in that area and who are the most vulnerable? Thank you.
Thank you very much, Professor Rees and Messeret. If Leon from the Nation is around, please go ahead and ask your questions. Leon.
Thank you very much. There are global reports of a vaccine-derived polio being on the rise. And interestingly, we have a new vaccine which aims to stop that spread. And so far, 25 countries have, as of last year, 25 countries reported cases. And for example, Uganda has, by January, it had administered 8 million doses of the new vaccine. Now, my question is, what is causing the new vaccine-derived polio? Because I've been researching on it, and I see scientists pointing to the fact that there have been gaps in our immunization. And should there be a cause for alarm in this regard? As we've seen wild polio, type 1 polio in Malawi.
Thank you very much, Leon. Dr. Richelot, would you like to answer that question, please?
Yes, good morning and thank you. Yes, in fact, now we have new virus-derived polio, and we have a vaccine, Hpv vaccine, who is very good in stopping outbreak. So now what we are doing is to prepare those countries to be ready to use the Hpv vaccine. And so far, more than 20 countries have been using this vaccine. So the last part of the questions, when we compare with the white polio virus, yes, in terms of outbreak, if we don't stop the outbreak, we will have the same effects like white polio virus. But with the vaccine that we have, we are confident to ready to stop these outbreaks. Thank you.
Thank you very much, Dr. Richelot. The next question is coming from Nyaradzi Makoni, and he says, how can increasing COVID-19 vaccination across different African countries be achieved? And what are the approaches needed that might differ to those taken elsewhere? And this question will be for Dr. Benito, please.
I think the first thing we need to realize what has happened in terms of COVID-19 vaccination in this region. During the first phase, we were struggling with accessing the vaccines, and then as the situation of vaccination, supply of vaccines improved, many countries started relaxing their public health measures. So we are closely working with, there's a reduced risk perception, and in a situation where you can see more and more we are having few cases and deaths. But if you follow what is happening globally in one of the countries, you will see that we are still having cases. So what we are trying to do right now in terms of making sure that we can scale up COVID-19 vaccination, it's really a combination of strategy. There are countries that are, for instance, using COVID mass vaccination campaigns. And through that approach, we've seen an increase in uptake of vaccines. Others countries are also targeting the most vulnerable population, what we call the highest priority groups, like healthcare workers and those who are having those who live with comorbidities. So we are trying to diversify, in fact, our strategy to ensure that we can, first of all, achieve the high coverage in priority groups. And then as time goes on, we now go to the lowest kind of priority groups. So there's a lot of efforts going on right now with Gavi, UNICEF, and WHO closely working with countries to address some of the bottlenecks that are preventing vaccine uptake in the region. One of them being really the low perception of risk of the disease. So there's a lot of work going on, and we hope that maybe by the end of this year, we can have the percentage of people reach can increase substantively. Over.
Thank you very much, Dr. Mpuma, for that comprehensive response. May we ask the Minister of Health from Mauritius, the Honorable Dr. Kelesh, to just give us a response from a country-based response that you had. Thank you.
Yes. Now, I believe that last year the perception for vaccine acceptance was in some context, and this year there is a different context. There is a different perspective on the vaccine acceptance. Last year, we had the emergence of variant, the Delta variant, causing high rate of mortality. So you have to adopt strategies to deal with that to make your vaccine acceptance on the rise. Now, this year, now we all know what is the situation around the world with the variants. Omicron is here, and what has been the impact in terms of severity, in terms of infectivity. Now, over here now, at this stage, to get vaccines, to encourage vaccines in the population, so defined strategies is required, because at this moment we can't use the same strategies that has been, you have used it last year. Now this year, it's very important to do another set of awareness, especially especially for African countries where the vaccination rate is still very low. How the awareness campaign will target people to accept vaccines, because there would be in a population where you don't have a good proportion being vaccinated, what is the possibility of having new variants, and how this is going to impact the economy, how it's going to impact schools, how this is going to impact borders, opening our borders with other countries. So that has to be the main message to countries, so that we can keep on roll across the vaccination campaign. Thank you.
I thank you very much, Dr. Kelesh. May I ask Professor Rees to add on to what has been said by both Benito and Dr. Kelesh. Thank you.
No, thank you very much. And it's an important question. I think the first thing I just wanted to add on was that the vaccine hesitancy that we've seen, and it's something that obviously we've all been very concerned about, was partly contributed to by the delay in accessing vaccines. It allowed misinformation, disinformation to come in, but it also allowed questions to be raised at a population level about, well, is this disease really as bad for us as it is, as we see in the Northern Hemisphere? And people wouldn't necessarily understand that we have different demographics, we have younger populations, we're going to see more asymptomatic, mild infections. But nonetheless, there is a question in terms of science that we should look at to really understand our local epidemiology. But the other thing I wanted to say is that, and Dr. Benito said it, is that the aim of the vaccine campaigns is to prevent severe disease and hospitalization and overwhelming of health services and deaths. And that means that high priority group remains there. But when we look at the rest of the population, one of the things that we now have to look at, and this is where science must come in as a rolling scientific set of questions, is that we have in our region what's called high seropositivity. That means a lot of people have got antibodies. The majority have got antibodies probably from natural infection rather than having been immunized. So if we've got 80, 90%, particularly in the urban areas and the dense areas of people with antibodies, do we need to, can we, should we change our approach to the immunization of those populations? And so just to give everyone a heads up, there's a big discussion now that's going on globally, it's going on in the region, about what's called hybrid immunity. So if we've got high seropositivity, can we adopt a different approach to vaccination, for example? If we know that many of our 20 to 40-year-olds are out in the world, have already got antibodies, 80, 90%, can we give a single dose of vaccine, for example? Now, there's no answer to that yet, but I think the point I wanted to make is that this is rolling science. And we've got to keep on top of it in our region. And we shouldn't think that the rolling science is only going to be answered from high-powered laboratories in the north. We need to look at our epidemiology, understand the vaccines available to us and our constraints, and then think what really makes sense in terms of getting protection up in our communities. Thank you.
Thank you very much, Professor Rees. Now, we would like to hear a question from Paul Adepoju. Paul, please go ahead.
Thank you very much. My first question goes to the Minister. There has been this really huge call among led by the African Union for Africa's vaccine sovereignty, but we've not really heard much on this topic from your country. So I'd like to know your country's position on vaccine sovereignty and whether the development around COVID has really encouraged and motivated the government towards spending more on accessing vaccines and not just waiting, relying on donated vaccines. For Professor Eileen, you started what I would like to ask, but I would like you to take it further, which is reimagining Africa's vaccination initiative. What do you think Africa can really do to make its vaccination efforts more efficient, such that when new diseases happen, we are not just using the same way that we do things to quickly roll out vaccines? What vacuum do you still think exists that we can look at local solutions to make our vaccination initiative more effective? Thank you very much.
Thank you, Paul. The first question goes to Dr. Kelesh.
Yes. So I totally agree with that. The question of what do we do, because at present, so far the information that we do have, the production of vaccination in Africa being very low, probably somewhere less than 1%. If you look at the whole continent, the requirement for vaccination, and the element of whether at this moment is it possible for vaccine to engage into the production of vaccination, so that will require quite a lot of information before we can really engage in our own vaccine production. Now, the misinformation, yes, so that's we have faced it quite a lot since the very beginning, to have a lot of misinformation on vaccination, especially with all the media that we do have. How do we work on that? It's a question of what's the means that you do use to have your proper your communication, because it's been around the world that you've got the misinformation being circulated all around, and this will create a lot of issues. Now, Mauritius, in its last budget, has created the space for for pharmacy industry in Mauritius, but yet this is still at a very premature stage, and that will take some time to have the right person and to engage the right production of vaccines, respecting all the legal issues and the licensing. So it's just we just in the beginning of this adventure. Thank you.
Thank you very much, Honorable Dr. Kelesh. The next question was for Professor Rees. Please go ahead, Professor Rees.
Thank you. So it's a very good question. What can we do? What can we learn from COVID in particular to make our vaccination efforts more efficient? And I'm building on the Honourable Minister's comments. The first thing I think we need to think about is we tended to say manufacture, but manufacture is in a whole line of development, is the end. So what we need to do is start at the beginning and strengthen vaccination research. Lab research on the one hand, and we've already seen that the network of labs with COVID has really grown. So lab research, clinical trial research. One of the initiatives during the COVID vaccine was a coalition dedicated to try to increase the low middle income country capacity to doing clinical trials. The regulatory side is critical, and we've talked about the African Medicines Agency, but actually WHO is also now trying to upgrade all national regulatory authorities by awarding them what's called a maturity level. And that's really creating a sort of impetus for regulators to really think about how they do their business. And then, of course, manufacturing, which is a science and a skill all of its own, and we need to build that up. So that whole scope needs, from A to Z, needs to be strengthened. That's the first thing. The second thing, though, is I'm going to stick on the science for the moment, and that is we need to think about new technologies. We've been very dedicated to needles and syringes, and one of the things we learned in COVID is that there was a shortage of needles and syringes. And that was a shortage that wasn't only for COVID vaccines, but was a global shortage. But there are other technologies that we can think about, and we are thinking about them for COVID. We should think about them more generally. Intranasal technologies, patches that you can apply. Now, if you have simpler technologies, it means your rollout is easier. It's easier to roll out an oral polio vaccine than it is something with a needle and syringe. So we need to say, what is an appropriate set of technologies for our setting, and also to try and create vaccines that have got more and more antigens in them, if we can do that, because that means fewer vaccines, fewer visits, and cost to health service. The third one, I think, is that, and we are thinking about this in terms of vaccination efforts more efficient, is we need to think about the potentially vaccine preventable diseases that we haven't tackled. And I'll give Lassa fever as an example. There are efforts now with groups like CEPI to actually try and invest in these vaccines. But if we want to be ready for the next pandemic, we need to look at the whole row of pathogens that we have. Ebola we know about, but there are many other pathogens that we do not have vaccines for. And we need to now urgently sort of commit to developing those. And lastly, I would say, in terms of what you've asked, and the Honourable Minister has highlighted it really well, we should seize this moment, because the AU has been vocal, ministers are now being extremely vocal. We should seize the moment, not only for manufacturing, but to say that vaccines are incredibly important for the development of our continent. Thank you.
Thank you, Professor Rees, for that very comprehensive response, and also thank you to Dr. Kelesh. Excuse me. Our next question is coming from Prince Yassa from DRC. He is working with the Network of African Media for the Promotion and of Health and Environment. His question is, what is the reason for the resurgence of Ebola in the Equator province? And this goes to Dr. Keita.
Thank you so much for this question. But maybe as in the DRC, the ecosystem is favorable for Ebola reservoir. So what is certain, we will have outbreaks in Ebola in the DRC. But with the availability of vaccine and the drugs and the better preparations, I think, including at the community level, we hope that we can drastically reduce the lethality, the case lethality rate and the mortality of this disease in the DRC.
Just for the French-speaking people's sake, would you please respond in French as well?
Yeah, okay. So, in French, je disais que la situation, l'écosystème de la RDC est favorable au réservoir de virus ici en RDC. Donc, nous allons continuer à avoir des épidémies d'Ebola en RDC. Mais ce qui est le plus important, maintenant, on a le vaccin, on a le traitement spécifique, et avec une meilleure préparation, on peut réduire de façon drastique la létalité de la maladie une fois qu'elle survient. Mais ce qui est sûr, on ne peut pas dire qu'il n'y aura jamais d'Ebola en RDC parce que l'écosystème est favorable, le virus existe au niveau de l'animal dans la forêt et donc il peut y avoir toujours des transmissions de l'homme, de l'animal à l'homme, mais si on a tous ces éléments avec une meilleure préparation, on peut arrêter rapidement les épidémies quand elles vont survenir. Au revoir.
Thank you very much, Dr. Keita. Professor Rees wanted to just come in and weigh in on that. Thank you.
Just to build on Dr. Keita, the issue of animal reservoirs, if we're talking about things that we need to do more of in our region, one of them, particularly for COVID, it's very topical. We are concerned that COVID, we already know coronaviruses are extensively found in the bat population, but we are concerned that COVID coronaviruses could establish reservoirs in animal populations. But again, because we have limited resources, we are not able to do the same kind of research as you've seen in northern countries, but we're well-resourced on animal reservoirs. So if we were to put on the to-do list of things we should be doing, one of them is to look more closely at what we call One Health, and that's the relationship between animal health and human health. And actually think about our surveillance, not only for human diseases when they're in humans, but surveillance in animals as well.
Thank you very much, Professor Rees. The next question is going to come from Alex Winning from Reuters in Johannesburg. And his question is, based on the genomic sequencing data, it looks like the number of cases of the BA.4 and BA.5 Omicron sublineages are increasing in South Africa. Are there early conclusions we can draw about the sublineages based on what we are seeing in South Africa? Are they likely to be more transmissible than other sublineages of Omicron, for example, BA2? What can we say about the severity of disease that BA4 and BA5 are causing? Thank you. And that, may I ask Dr. Tieno to answer that question, and Professor Rees will weigh in on it.
Thank you very much for the question. And I think it's quite clear that we have not at the moment really noticed any increasing number of the cases of the death, related, to these new sublineages. We are monitoring them, I think, very closely. And if I do remember well, the sequences, the samples which were taken for detecting these new sublineages were done, in January, around the mid of January. And we have not seen any high increasing number of cases in both in South Africa, but also in Botswana, where the cases were reported. So at the moment, there's no really strong evidence mentioning there is really a kind of increasing number in terms of severity or transmissibility with those two new sublineages which has been mentioned. And this can also bring the other point about the capacities in terms of genomic sequencing in our region here. And it's important to mention it, as Dr. Benito said, some of the positive also messages, because there've been a quite of increasing, capacity in the region here, since the beginning of this pandemic for doing this genomic sequencing, activities. And today, almost all of our countries have those capacities. They have, all of the instruments, the norms, the capacities for doing so. And when we compare the situation in 2021, in comparison to now, we have seen that the sequences which has been generated from our region, have really increased for 5 times, since 2021 at the same period of the time. So I think this is quite something which is encouraging and on which we really need to continue and to continue this surveillance. And if you allow me, maybe just 2 main other points, I think, about the surveillance, the innovative surveillance tool, which has been currently, experimented in our region here. There is currently a set of action, for trying also to detect some of these components of the viruses in some of the wastewater, so a new approach for detecting, the presence of the virus in the communities. And last point I would like maybe to bring here also, it's about the necessity of really adapting all of our response measures. We've been talking about it quite enough, but it's very important that in the region here we see, given the dynamic of the pandemic of the region, all of the effort, the past experiences, but also our characteristic, really to adapt our response strategies. So this is something which is, I think, a learning from us, and not all time, to try to do some kind of copy and paste, from what have worked somewhere where, the context, the elements are different in comparison to our region here. Thank you, and back to you, Zora.
Many thanks, Dr. Balde. May I ask Professor Rees to weigh in on this one?
No, thank you. And thank you very much. And I'm going to be very naughty because I've got hot off the press data, which I can build on Dr. Tierney's comments. So the new lineages B4 and 5, and I must stress that this is in-house South African data, so nobody else would have probably had an opportunity to look and wouldn't have been necessarily shared yet with WHO. So it's quite right that we are seeing more of this BA4 and BA5 as these new Omicron lineages. And we're seeing that there are an increasing share of cases in South Africa. So the numbers of cases are going up, but increasing share are this BA4 and 5, which suggests that they might have a growth advantage over the previous sublineages. And we're getting more cases now and more test positivity. I want to stress this is really like 24 hours hot off the press. What we're seeing, and it's anecdotal, it's from private sector and from hospitals, is what we saw when Omicron started in terms of who is going into hospital first, but we don't know how to interpret it, is once again, we're seeing it first with children. But we think that with children, there's several things. One was that we think quite a lot of the original findings with Omicron were coincidental because children coming in with respiratory diseases just were co-infected coincidentally, and that Omicron wasn't necessarily the cause of their illness. And also because people are much more cautious probably with children and hospitalization. And when the hospitals aren't full, people will possibly hospitalize earlier. So I think BA4 and 5, just to build on what's been already said, as we saw with the original Omicron, would appear to be more, now representing a larger and growing percentage. And it's been found in 7 of the 9 provinces in South Africa. So we must watch that space. But so far, we're not seeing a huge increase in mortality or ICU admissions, but the numbers of cases being admitted are going up as the numbers overall go up again. Thank you.
Thank you once again, Professor Rees, for that very comprehensive response. The next question is coming from Lucia Blanco from the International Spanish News Agency. And her question goes to Dr. Keita. Do we know if the outbreak is connected to any of the previous ones? The province of Equator already experienced an outbreak not that long ago. How many people were already vaccinated in that area? Thank you very much. Dr. Keita.
Okay, thank you so much for this question. Just to mention that the first sequencing result revealed that this current outbreak is not linked to the previous. So it's a new spillover of the virus. So, but in terms of vaccinated people, as I mentioned in my intervention, we have already vaccinated yesterday 78 contacts. But in the previous vaccine outbreaks, for instance, the previous one, I think we were able to vaccinate around 40,000 people in the Equator province. So, but these outbreaks affected, I think, 13 health zones. So we vaccinated in all of these 13 health zones. And in overall, we vaccinated around 40,000 people, if I remember well. Over to you.
Thank you very much for that response, Dr. Keita. We have now come to the end of this virtual press conference and would like to hear from our panelists to just give any final messages in 1 minute, please. Could we hear from Dr. Kelesh? Dr. Kelesh, please.
Yeah. Now, that's good that we had this conversation among ourselves and in the patronage of the WHO. Now, it's really time that we think when we hear Professor Rees, all the scientific basement of the whole of Africa, the vaccination program, the emerging diseases, and what we have experienced now. It's time that we work out that collaborative approach, that coordinated countries to build up our, it's just one country, it's a village that we have to work together and ensure that our population, be it from northern side or the southern side, we all build up to reach that vaccination level and see what is the urgent needs, because we've got to see our priorities, especially in terms of vaccination. We speak on Ebola, we speak of all those different other diseases that are here for quite a long time. And for us to spend, at the same time, looking at emerging diseases and taking care of what's been happening for the last 20 years now, I think we have to elaborate this coordinated approach. Thank you very much.
Thank you very much, Dr. Kelesh, for those encouraging words. Professor Rees, could we have your parting words?
Well, I think this discussion has shown us, if we didn't all know it, how important vaccines are. We've heard about measles and polio, well-established vaccines that we're not getting out. We've heard the importance of the radical impact that Ebola vaccines and COVID vaccines have had on outbreaks and pandemics. And we've heard about the threat of new pathogens and the need for sustained surveillance and good laboratory and good genomics. But I think as we do that, we should also revisit some of the things that we might not have done so well. And if we're talking about a life cycle approach to vaccines, one of the issues that we should be thinking about in this region is really getting HPV vaccines out to the population. WHO's SAGES committee has now said we only need a single dose. We can choose to give 1 or 2 doses. We are not getting a life-saving vaccine out. And this is now targeting particularly young women for a disease much later in life. So we should rethink very actively, where we're not doing so well, what we can do better. And then just to say, we have the excitement of rolling out, albeit in limited amounts to begin with for the first few years, the first malaria vaccine. So this is such a dynamic field. It's just great that WHO has taken this initiative, and hats off, Honourable Minister, to yourself and to your ministerial colleagues who've really taken vaccines forward, I think hugely during the COVID pandemic. Thank you very much.
Thank you so much, Professor Rees. And your words actually remind us of the African Vaccination Week theme, which is long life for all. Dr. Impuma, please wrap up for us. Thank you.
Well, thank you very much. Maybe I'll say three key messages. The first one, the pandemic is not yet over. As you've seen, we're still seeing cases and deaths here and there. So it's not yet over. And then we need to just continue applying some of the public health measures. The second key point from this discussion is really the role of vaccines as one of the most important public health tools to not only prevent many of the outbreaks that are happening in our region, but also contribute to the response to the outbreak. So it's extremely important to make sure that we have vaccines available and then people can get vaccinated. The third one is really what Professor Hayden was mentioning, the role of science and research in guiding our work as far as the preparedness and response to outbreaks is concerned. So it's extremely important that we continue to rely on the guidance and orientations that are given by our researchers to support our effort to deal with some of these outbreaks. And then lastly, what we've been discussing on Ebola in DRC, but also in what we've seen in other countries, the critical role of investing in surveillance, in strengthening the collaboration between those who are dealing with like the animal side and those who are working on the human side. So the so-called One Health approach, which promotes the collaboration between different sectors to ensure that we can detect these outbreaks quickly when they are really at their early stage, so as to prevent deaths and other complications. I would like to take this opportunity to once again thank, on behalf of WHO, the Honorable Minister of Health and Professor Helen Rees and all the journalists and our colleagues for joining this press conference. Thank you so much for your time and availability. It's greatly appreciated. Back to you.
Thank you very much, everyone. We would like to just add that we are going to have a French version where Dr. Tieno and Dr. Keita will be addressing in French. So please stay on if you'd like to get the French version for everyone, please. Thank you very much for your time. And to all our panelists, thank you very much for the wonderful information that you have shared.
Thank you.
Thank you, Zora.
Thank you. Bye-bye.
Bye-bye.
Bye.
Bonjour à tout le monde. Donc, c'est la session francophone. Ici, Khadija Diallo. Je voudrais confirmer, Dr Mori et Dr Baldé, êtes-vous toujours en ligne?
Oui, Khadija, je suis en ligne.
OK. Donc, Dr Mori, dites-nous, je pense, juste peut-être 2 minutes, un point par rapport à l'épidémie actuelle en RDC, s'il vous plaît. Merci.
Merci beaucoup, Khadija. Comme vous le savez, nous sommes à la 14e épidémie d'Ebola en RDC, la 3e dans la province de l'Équateur depuis 2018. Alors, depuis la déclaration de l'épidémie le 23 avril dernier, nous avons déjà rapporté 2 cas confirmés. Et tous les 2 cas sont liés, donc issus de la même famille. Et tous les piliers de réponse sont déjà fonctionnels sur le terrain. Et donc, la réponse est en cours. Et nous avons commencé la vaccination hier. Et pour la vaccination, pour la seule journée d'hier, nous avons vacciné 78 contacts. Et donc, les 3 équipes de vaccination sont fonctionnelles pour le moment et ils vont continuer à travailler aujourd'hui et les jours suivants pour vacciner le plus rapidement possible tous les contacts et les contacts des contacts. Donc, les autres interventions, les autres piliers sont également en cours d'être mis en place et c'est ce que je peux dire. Le plan de réponse au niveau national est pratiquement élaboré avec le ministère. Donc, l'OMS a appuyé cette élaboration et c'est ce plan qui va bien sûr guider toute la réponse. Donc, ceci a déjà été fait et globalement, nous sommes à ce niveau et nous sommes en train quand même de renforcer les investigations épidémiologiques pour déterminer la source de contamination. Alors, comme je le disais encore, les premiers résultats de séquençage ont montré que cette épidémie est une nouvelle épidémie, elle n'est pas liée à la précédente et donc c'est une nouvelle épidémie. Merci à vous.
Ok, merci, Dr. Keita. Donc, je pense que ça répond également à la question de Prince Yassa du réseau des médias africains pour la promotion de la santé et de l'environnement. Et donc, il demandait en fait comment on justifie la résurgence de la fièvre hémorragique Ebola dans la province de l'Équateur. Et comme vous avez mentionné, ce n'est pas une épidémie liée à l'autre. Donc, ça répond à la question de Prince Yassa. Docteur Baldé, nous avons une question de Mbadjik Diouf de Radio Oxygène à Dakar au Sénégal. Alors, il voudrait savoir, donc la plupart des vaccins utilisés dans le continent nous viennent d'autres continents. Concrètement, il voudrait savoir qu'est-ce que l'OMS peut faire pour que les pays africains puissent avoir une autonomie vaccinale. À vous, Docteur Baldé.
Merci beaucoup pour la question. Je pense que nous avons énormément appris avec la pandémie donc de la COVID-19, donc de la nécessité d'avoir vraiment des capacités de production locale, nationale ou bien régionale, non seulement des vaccins, mais aussi de tous les autres produits et équipements médicaux. Mais pour revenir aux vaccins, je pense que l'OMS a déjà pris vraiment les devants. Il y a déjà presque un peu moins d'un an qu'il y a eu une initiative vraiment pour pouvoir encourager de nombreux pays, notamment des pays comme l'Afrique du Sud, d'autres pays comme le Nigeria ou encore d'autres pays qui sont situés en Afrique du Nord pour produire donc ces vaccins-là qui pourront être utilisés sur notre continent. Mais peut-être qu'il y a lieu aussi, en plus de cette production-là, je crois que les collègues l'ont mentionné, il nous faudrait avoir quand même une approche un peu plus holistique un peu sur cette problématique de la vaccination. À un moment donné, on a vu que l'un des enjeux importants, c'était la non-disponibilité des vaccins. Par la suite, les vaccins ont été disponibles et là, on fait face à un autre enjeu un peu de l'acceptation un peu de cette vaccination-là, de la prise de la vaccination. Donc, je crois qu'il y a beaucoup d'éléments, il y a beaucoup de paliers, il y a beaucoup d'étapes qu'il nous faut quelque part adresser donc tous de façon collective. Et nous saluons le travail probablement donc de la presse et des journalistes, des communicateurs pour pouvoir nous accompagner dans cet exercice-là. Parce qu'à la fin, c'est vraiment l'adhésion des communautés, l'explication de ces phénomènes-là et nous aussi un effort vraiment important pour pouvoir adopter et adapter vraiment les messages que nous passons pour que ces communautés-là, ces populations soient bien engagées à accepter donc cette vaccination. Et la COVID-19 fait ressortir cet enjeu-là, mais c'est un enjeu qui s'applique aussi à toutes les autres maladies donc à potentiel épidémique ou bien pandémique. Donc voilà, j'espère que ça répond à votre question.
Merci, Dr. Baldé. Dr. Mori, nous avons également une question de Jeannette Kamouissi qui voudrait savoir par rapport à la résurgence de la maladie à virus Ebola, est-ce que les causes de cette résurgence, est-ce que c'est connu et vulgarisé à toute la population? À vous, Dr. Mori.
Oui, en fait, comme vous le savez, la RDC, l'écosystème de la RDC est très favorable au réservoir du virus Ebola. Et donc, nous allons toujours continuer à avoir le virus au niveau animal et la transmission de l'animal à l'homme pourra toujours survenir à tout moment. Et donc, c'est pourquoi, comme le disait tout de suite Dr. Benito, on doit pouvoir renforcer cette approche One Health ici en RDC. Mais ce qui est le plus important, c'est qu'aujourd'hui, nous avons un vaccin Nous avons des médicaments et avec une meilleure préparation. Et juste pour vous rappeler, si vous prenez les 4-5 dernières épidémies, pratiquement ça survient toujours à la même époque, à la même période. Cette année, c'est en avril. L'année dernière, vous verrez qu'il y a beaucoup d'épidémies qui surviennent à peu près à la même période. Donc, on peut tirer des leçons là pour qu'il y ait une meilleure préparation au niveau de la communauté, avec bien sûr un renforcement de la communication du risque et de l'engagement communautaire. Et donc, avec cela, on peut réduire la létalité une fois que l'épidémie survient, parce qu'il y a les médicaments, il y a le vaccin. Mais on ne peut pas dire que l'épidémie ne va jamais survenir en RDC. En tout cas, avec son écosystème, c'est très difficile de dire qu'il n'y aura jamais d'épidémie d'Ebola. Merci à vous.
D'accord, merci, Dr. Keita. Donc, par rapport à cette épidémie, c'était un peu vos derniers mots ou bien il y a quelque chose que vous voudriez rajouter à l'attention des journalistes francophones et de la population? Dr. Keita?
Oui, ce que je voulais peut-être ajouter, c'est que on a quand même une fenêtre d'opportunité. Pour le moment, nous n'avons que 2 cas confirmés. Donc, c'est une fenêtre d'opportunité pour nous pour aller vite et arrêter rapidement cette épidémie. Donc, tous les partenaires, l'OMS et tous les partenaires impliqués dans le domaine de la santé et sont sur le terrain en train d'accompagner le ministère de la Santé pour arrêter rapidement cette épidémie. Nous savons que chaque épidémie est unique. On ne peut pas parler avec certitude, mais nous pensons qu'avec les moyens à disposition et un fort engagement communautaire, on peut espérer arrêter cette épidémie le plus rapidement possible. Merci à vous.
Merci, Dr. Keita. Dr. Baldé, un point par rapport à COVID pour 1 minute ou 2 avant qu'on se quitte?
Merci beaucoup, Khadija. Je pense que l'essentiel là pour nous, c'est effectivement de pouvoir mieux comprendre ce à quoi on est passé au travers pendant les 2 dernières années et peut-être vraiment essayer de construire le futur en fonction de cela. On est à cette phase-là où on a vraiment une phase relativement déclinante, un peu autant en termes de nombre de cas qu'en nombre de décès. Évidemment, on aura toujours des fluctuations avec la saison fraîche qui arrive en Afrique australe. Donc ça, c'est un enjeu important. Il faut qu'on continue à avoir ces capacités de réponse-là. Mais il nous faut aussi continuer vraiment à réfléchir pour pouvoir mieux gérer les prochaines épidémies dans notre région. Et pour cela, je crois que vraiment une contextualisation, une fois de plus, je me répète, une contextualisation de nos moyens de réponse est quelque chose de fondamental. Depuis le début de cette pandémie, on a vu une appropriation importante des pays, donc à tous les niveaux, véritablement, donc surtout au niveau politique, donc au niveau opérationnel, donc pour pouvoir avoir une réponse robuste et une réponse concertée. Donc, on se rend compte quand même qu'on est capable de le faire et donc et que l'on puisse donc, comme on dirait en anglais, tailorer, en tout cas dimensionner vraiment nos réponses en fonction de notre contexte, c'est quelque chose d'extrêmement important. Évidemment, l'engagement de tout le monde, l'engagement un peu des communautés, cet apprentissage-là, ces échanges-là, ces dialogues-là, pour qu'on ait tous la même approche, je pense que ça, c'est aussi quelque chose aussi de très, très important, en plus de tous les autres éléments un peu techniques et médicaux sur lesquels donc, nous travaillons continuellement. Et pour finir, l'OMS définitivement est toujours engagée donc, auprès de ces pays-là, auprès de ces communautés, pour pouvoir identifier donc, toute upsurge, toute augmentation rapide donc, du nombre de cas, évidemment, donc pouvoir mobiliser les ressources qu'il faut pour circonscrire ces nouvelles flambées et répondre donc à cette épidémie-là. Je vous remercie.
Merci à vous et merci à tout le monde. Merci aux journalistes qui se sont connectés et à la prochaine fois. Au revoir.
Merci, au revoir.